This is the human side of healthcare, where we explore all aspects of today's ever-changing healthcare environment. Brought to you by the Dallas-Fort Worth Hospital Council and featuring CEO Stephen Love with co-host Thomas Miller. Now, let's make healthcare human again.
Welcome to the human side of healthcare. Delighted you're with us today. You know, as we get into the fall and the winter, we think in terms of having colds, the flu, but also pneumonia. And it really impacts everyone, but especially older adults. We're delighted we've got Dr. Michael Tolle with us today. He practices family medicine at Texas Health Presbyterian Hospital in Dallas. Dr. Tolle, welcome to the show.
Thank you very much.
You know, as I mentioned in the introduction, flu season is here. But when you see patients, how do you differentiate the common cold, the flu, and pneumonia?
That's a great question, because that's a very common clinical scenario in offices like mine. I'll go ahead and start with a common cold. A cold gives you what we would call upper respiratory symptoms. So these would be things like sniffles. You might have a cough, but something's coming from what we call the upper airway. Again, particularly the nose, maybe a sore throat. There are these types of symptoms. Pneumonia, by definition, is inflammation in your lungs. So that's your lower airway. So you certainly may have a cough. You almost always do. But something's happening in your lungs. It's an inflammatory process. And so by nature, it's more severe than a common cold. The flu often presents like a cold and then can progress to pneumonia. So it can give you both sets of symptoms. So if somebody calls up or somebody comes in and says, yeah, I've got sniffles and a cough and a sore throat, and I've had the symptoms for a day or two, we're probably dealing, but they're not short of breath, not having a fever. We're probably dealing with a cold. When you have pneumonia, one of the most prominent symptoms you have is shortness of breath. You often have a fever, you often have fatigue, and you just feel more ill. So if the infectious process or the inflammatory process has gotten into your lungs, you have pneumonia. We'll hear that when we listen to your chest. We'll see that on an x-ray, but it's down in your lungs. The flu, think of it like a more severe common cold that can lead to pneumonia.
You know, if someone presents to you and they have all those symptoms you talked about, do you first test for COVID? Does COVID symptoms overlap with pneumonia symptoms?
Yeah, COVID certainly has changed the equation a bit the last few years. COVID can present, I think as we're all familiar from the last couple of years, can present anything from a very mild upper respiratory illness to a severe lower respiratory illness to a pneumonia case. We do test for COVID. Very often patients test for COVID at home these days with the widespread availability of the rapid test. So very often these days, by the time somebody's contacting us, they've already tested for COVID. Around the beginning of this year, the dominant COVID strain changed to, as we know, the Omicron variant, and then some of the subvariants of Omicron. These do seem to give people more of an upper respiratory presentation than the original COVID. We've seen a lot of cough and sore throat, kind of like a flu or a really bad cold, that have been COVID Omicron BA strain infections. Although, of course, some of those can, like the original COVID strain and the Delta strain that we're seeing in the earlier time of the COVID pandemic, the Omicron variant can lead to a pneumonia case also.
What type of pathogens cause pneumonia?
The classic pneumonia pathogens would be bacteria. So these would be, in fact, probably the most classic is a bacteria called pneumococcal bacteria. And I think we'll probably talk later in this session about vaccines for pneumococcal bacteria, because they're a major part of preventing pneumonia. So bacterial pathogens. You get pneumonia, you take an antibiotic. We're all used to that paradigm, if you will. Other organisms can cause pneumonia too. Anything that can inflame your lung. So in a patient who's immune suppressed, a fungus can cause it. Viruses very commonly cause pneumonia in all sorts of people, from people who have a normal functioning immune system to those who is not functioning as well. Again, we talked about COVID-19, but a real plethora of viruses can cause an inflammatory reaction in the lung, a lower respiratory tract infection, which is pneumonia. So bacteria and viruses are going to be the major pathogens causing pneumonia. Viruses, as we've seen from COVID-19, can be particularly tricky and difficult to treat because where we have a wide range of antibiotics for bacteria, there's much less in the antiviral armamentarium in terms of treating. As we've seen from COVID-19, viral pneumonias can be quite severe.
To help put pneumonia kind of in perspective, do you have any national statistics you could share?
Yeah, the most commonly quoted national stat is something on the order of 1 million emergency room presentations for pneumonia every year. And if you add in urgent care and regular doctor's offices like mine, it's obviously much more than that. But 1 million ER presentations, that's a lot. It's a major issue. Something on the order of 50,000 or so deaths related to that annually also. So it's a substantial health problem in the United States and also here in Texas. In Texas, we see about the same rates of pneumonia as we see across the United States. So this is something that you see everywhere. If you're a doctor working in an office or urgent care ER, you're going to see a lot of pneumonia cases every year.
At the outset, we mentioned the elderly population and pneumonia. Can you explain how life-threatening it can be to the elderly?
Yeah, elderly population and really anyone whose system is relatively weak, pneumonia can be quite threatening. Because we mentioned how pneumonia is an inflammatory process in the lungs, what happens when you have inflammation in your lungs is you can't exchange oxygen from the air you breathe in to your bloodstream as well as you should. If your oxygen level is not high enough, then tissues throughout your body suffer. And so your kidneys and other organs begin to have dysfunction related to not having enough oxygen. A bacterial pneumonia, particularly bacteria, can pass into your bloodstream, cause a bloodstream bacterial infection, which is more serious. Older individuals have naturally less function of the immune system typically than younger people. So there's a little bit of natural immune suppression, which just goes along with being older. And your overall reserve is lower. You're more likely to have something like coronary artery disease, where you're already set up for an issue. And if you have a low oxygen level, then the blood getting to your heart is, already perhaps struggling through your coronary artery disease and low oxygen. Another thing I think that really stands out with the elderly population is this can present with confusion, which may be, if you're not confused at baseline, that's very noticeable to you or your family, but maybe not quite as noticeable if someone has some baseline confusion. And also just the ability to have attention paid to you, to have your condition recognized early, to be able to access care promptly. All of these are more of a struggle for our elderly individuals.
This is Dr. Michael Tolle. He's a family medicine physician at Texas Health Dallas, talking about pneumonia, not only how we can protect ourselves, but especially our youngest and our oldest. More on that next on the Human Side of Healthcare.
This is the Human Side of Healthcare, where we feature healthcare's hottest topics and what our North Texas area hospitals are doing to make healthcare human again.
Welcome back. What might seem like that common cold or flu could turn into pneumonia for yourself or for a loved one, especially those who are younger or older. We're talking with Dr. Michael Tolle. He's a family medicine physician at Texas Health Family Care. Steve?
I hear sometimes where elderly people, as you know, fall. And I've heard over, the course of my life where an elderly person fell, broke their hip, immobilized, and developed pneumonia. Is that something that could happen?
Yeah, that's absolutely an issue. So for all of us, we've got to be able to expand our lungs in a normal way, expand our lungs, get air in, contract our lungs, get air out. And if we're not doing that, when you're immobilized, you're injured, Particularly if you're older and you're injured, you're not expanding your lung fully when you take a deep breath. So that part of the lung, air is not flowing into and is much more prone to developing pneumonia. If you have an injury where you become unconscious, you may have what's called aspiration, where some of your gastric contents get sucked into your lungs, and very often you'll have a rather severe form of pneumonia called aspiration pneumonia from that. And that often goes along with somebody who's injured. Someone falls, breaks their hip, they're down, they might aspirate, they're not pulling in enough air, and just a constellation of factors which can lead to a pretty bad pneumonia case.
You mentioned aspiration pneumonia in your answer. Are there other forms of pneumonia that you want to highlight for our listeners?
Yeah, I think probably the most important form is what's called community-acquired pneumonia. This is when you go for your primary care visits, particularly if you're over 65, you're going to be recommended to have vaccines against pneumococcal bacteria to prevent one of the major forms of community-acquired pneumonia. Just by definition, the name means that you acquired this illness out and about around the community. Somebody may have been ill with a pathogen, and you inhale that pathogen due to contact with that individual, or through some other form of contact. But you acquired this just out and about doing your normal things on a regular day. Probably the most important thing. I think the second most important thing would probably be, again, just keeping our eyes on the unique situation we're in with COVID. Flu also, we always think about flu prevention as, preventing a case of the acute flu, which makes you feel so bad and stay home from work. But flu is a big driver of bacterial pneumonia cases. So you get the flu first, and then quickly followed by a bacterial pneumonia and quite ill. So kind of all that wrapping together, virally induced and regular community-acquired pneumonia.
You said it in your answer, but I just want to be clear. If a family member has pneumonia, it is contagious, correct?
Great question. That comes up a lot. So again, the last couple of years, who in our community is not tuned into the concept of a communicable disease at this point? So if you have an 85-year-old relative who develops pneumonia, most likely that is not a contagious case to anybody else in the house. That's a function, as we were talking about, of their advanced age, their relative immune suppression, and pneumonia developing in them for reasons particular to them. So not contagious to anyone else in the house. Viral pneumonias are more likely to be contagious because the viruses themselves are more easily transmitted from one person to another. But typically, unlike, say, a case of COVID, where one person has a case and all other 9 people who were at the dinner end up with COVID, pneumonia cases, typically those pathogens are more difficult to transmit person to person, say within the home. So it's not common to see multiple people come in with a pneumococcal bacterial pneumonia.
As a physician, as you're addressing older adults, and I'll define that as 65 years of age and older, what do you tell them and their families are ways to prevent getting pneumonia?
Yeah, I think the very first thing is to have a healthy lifestyle, to exercise every day, to have a very good diet, to manage your chronic medical conditions, particularly for diabetics, to make sure diabetes is well in control. And so again, good general underlying vigorous health, your number one starting point. Now that's not easy for everybody to do, but certainly important. On the medical interventions, we focus a lot, you mentioned 65 and up, we focus a lot on pneumococcal vaccines. A lot of people are familiar with the pneumonia shot. I want to get a pneumonia shot. That is a vaccine that covers, again, pneumococcal bacteria that are a major cause of pneumonia, and also one of the potentially really dangerous causes of pneumonia. It can get into your bloodstream relatively easily, et cetera. So the pneumococcal vaccine. Flu shots are extremely important. Again, so many cases are flu first and pneumonia second. Getting treatment promptly if you're feeling ill, particularly if you're having a fever, shortness of breath. Shortness of breath is a real key factor for people. If you're not usually short of breath, if this sniffle and a cough is associated with shortness of breath, that's something that really needs to be checked out.
Could you have pneumonia and COVID at the same time?
Yeah, you absolutely can. And again, it can be very hard to differentiate from, let's say someone has a positive COVID test and pneumonia. And what did we say pneumonia was? Inflammation in the lungs. So they've got a positive COVID test, they're short of breath. We listen to their chest. They have what we call crackles. You can hear the fluid on one side and nice air movement on the other side. So that individual has COVID, and clinically they have pneumonia. And is the pneumonia being caused by COVID? Is it COVID-19 that's caused that inflammatory reaction? Or did COVID set the person up, if you will, to have a bacteria make the move into the lung, and you have a bacterial pneumonia along with a COVID infection? Same with the flu. You have a fever, you have a sore throat cough, you have a positive flu test, you have clinical pneumonia. Is that flu in your lung? Is that flu and bacteria, just bacteria? Very difficult, I would say, impossible to tell purely clinically. And so one of the things that I think we've all learned to do over the years is to, assume that somebody has a bacterial process if they've got an acute pneumonia like that, and make sure that we are covering for that. But yes, you can absolutely have both. Even though very often it is the virus causing the pneumonia as well.
I'm going to switch gears now. Let's be positive. So you're diagnosed with pneumonia. Let's say you're older. What are some of the treatments there that can help you in this situation?
Well, certainly getting, we always start any sort of an urgent presentation with what we call the ABC. So that's making sure that your airway is good, you can breathe, and you have a good circulation. So, of course, addressing that right off the bat. If you come into the ER with a bad pneumonia case, it's going to focus on making sure that you can breathe, making sure you have enough oxygen. Most cases are not that severe. We see lots of pneumonia in the office. People may have a little bit of an oxygen deficit, not too much, don't need supplemental oxygen. Then the next most important thing would be covering with an antibiotic that will treat the treatable bacterial causes of pneumonia. A lot of the viruses, now we have some drugs that are very good at treating COVID specifically, and we have some drugs that are pretty good at treating influenza specifically, but for many viruses, for most viruses, we don't have any drugs that are capable of treating them. But we do have very good antibiotics, and so the patient placed on an antibiotic covering the common likely bacterial causes of pneumonia. So between making sure you have enough oxygen and making sure you have an antibiotic and making sure that you're hydrated, most patients are going to do very well. Again, most cases are office cases and treated with antibiotics and get better pretty quickly. And so it's a very feared diagnosis. I've noticed over the years, people get really scared when they hear they have pneumonia, even if they're not particularly ill. It just has a connotation to it, but almost everybody's going to get better.
Can pneumonia leave permanent lung damage?
That's also a very good question. Yeah, absolutely it can. So you can have the formation in your lung of what's called an abscess. We've all had bumps on our skin that have developed pus in them. I think most of us are familiar with what an abscess is. That can happen in your lung, can cause some scar tissue in your lung. It typically takes repeated lung infections, though, to give you a chronic change in the lung or a chronic lung condition. So first episode of pneumonia, I would say most typically does not do that. Have certainly seen that, but typically not. But repeated bacterial infections of the lung, particularly in someone whose lung might be damaged from prior smoking or other lung disease, over time can do that. But the first episode, again, if you're sick with pneumonia, you're almost certainly going to get better, and you're very unlikely to end up with a chronic lung problem.
This is such an important conversation on pneumonia from Dr. Michael Tolle, Texas Health Family Care. We're going to bring him back in our last segment. There's a term that doctors sometimes refer to as the old man's friend. We're going to explore that when he comes back. But next, a conversation about Crohn's. Next on the human side of healthcare.
Welcome back to the human side of healthcare, where we explore how to take better care of your health so you can live a happier, healthier life. With DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
Welcome back. Today we want to talk about Crohn's disease, and we're delighted that we've got with us Tasneem Ahmed, who is a physician dealing with gastroenterology at Texas Health Digestive Specialists, which is a member of the Texas Health Physicians Group. Welcome to the show.
Thank you. Happy to be here.
Let's kind of set the stage before we get into Crohn's disease. What is an inflammation of the bowel disease?
Basically, Crohn's disease, and you may also hear about ulcerative colitis. These are chronic inflammatory diseases of the GI tract. What that means is that there is inflammation occurring in the GI tract. And inflammation essentially means that there's swelling, there may be ulcers, redness, and irritation of the GI tract, either in the colon, in the small intestine, in different areas of your gut. And these are chronic conditions. And chronic means that these are lifelong type conditions that wax and wane throughout life. So you'll have periods where you're in remission and periods that you have flares. This is easily manageable, but these are a group of disorders that patients generally have to control and see physicians regularly and follow up.
When you look at the overall digestive system, what part of it is really affected by Crohn's disease?
So the most common area where Crohn's disease affects the gut is in the terminal ileum, and that is the last portion of the small intestine. And up to 40% of patients who have Crohn's disease generally have disease in that area. The rest of the patients will have disease in the colon, which is the large intestine, and a small percentage may have disease in the stomach, or what we call the upper GI tract, which is the stomach and the first portion of the small intestine. The unique thing about Crohn's disease is it can affect any part of the gut. And if you recall from, basic high school science, your gut starts in your mouth. And so Crohn's can certainly affect anywhere from your mouth to the anal canal, so from your mouth to your bottom, but most commonly it will affect your small intestine called the terminal ileum.
Are there tests for Crohn's disease? For example, would you discover it with a colonoscopy?
Yes and no. So the diagnosis of Crohn's can be challenging at times. It's based on a composite of symptoms and lab findings and colonoscopy findings and either CAT scan or MRI findings. There isn't a single test that is absolutely diagnostic of Crohn's disease. We look at the whole big picture of the patient. What are their symptoms? What do their labs look like? And yes, once we do blood work and we have a suspicion for Crohn's disease, the next step is a colonoscopy. However, sometimes if patients have disease deep into their small intestine that's beyond the reach of a colonoscopy may miss it, which is why we always try to get some sort of imaging, either a CAT scan or MRI.
So what would you say is the major cause of Crohn's disease?
That is a great question. And unfortunately, no one knows. No one knows exactly what triggers Crohn's disease. No one knows exactly what causes it. But the hypothesis is that there is some sort of imbalance in the gut microbiome. And you may hear that a lot. And the gut microbiome consists of billions and billions of bacteria. And they live in this perfectly well-balanced proportions. And either patients sometimes may have a genetic mutation, in which case that balance gets disrupted, resulting in an imbalance. And that then triggers what's called a dysregulated immune response, where for whatever reason, your body's immune system may recognize a bacteria or some sort of pathogen as foreign, and then stimulate an immune response where sort of the body is attacking the gut and causing inflammation. There may be something in the environment, certain foods, maybe certain medications, but essentially the hypothesis behind Crohn's disease is that it's a dysregulated immune response to something in the gut microbiome.
To help our listeners kind of comprehend this, how common is Crohn's disease among our population?
Crohn's disease, in terms of looking at the whole world, it's most common in developed countries. So here in the US, Canada, the UK, Northern Europe, I think last time I checked in America, it's about 1.5 million people are affected with Crohn's disease. So it's about, I would say, 1.5% of our population. So it's not rare by any means. I mean, when you ask people, they probably know someone in their life who's been affected by Crohn's disease. And the rates of Crohn's disease are rising throughout the US and as well as in developing countries. So it is a somewhat common disease that you will hear about or perhaps see.
You mentioned something in your answer. Can it be caused by food we eat?
Absolutely. That's a great question. And this is perhaps a big reason why we see these autoimmune diseases. And Crohn's is an example of an autoimmune disease like rheumatoid arthritis or psoriasis or asthma per se. And so developed countries, our diet may not be as healthy as others. We probably eat more red meat, more processed foods, more sugar, more artificial sweeteners, less fresh fruits and vegetables. And these are all things that we need for a healthy gut microbiome. And so what you put into your gut is what your gut puts out to you. And so it's very, very important to eat a well-balanced diet. And that definitely contributes to Crohn's disease. And the reason why we're seeing developing countries have higher rates of Crohn's disease and other autoimmune conditions is because they are now adapting more of a Western diet. You'll see more processed foods, more red meat, maybe less fresh fruits and vegetables in those areas.
So let me ask you this. If your parents had Crohn's disease, are you likely to have it?
That's a great question, and that's something we're often asked by our patients in the clinic. And when you look at the statistics, when one parent has Crohn's disease, the chances of this passing on to his or her children is likely less than 5%. So not common at all. Now that changes if both parents have Crohn's disease, then the chances of this Crohn's disease being passed on to the next generation is upwards of greater than 20%. So unfortunately, you can't change your genetics, and these are definitely things that we counsel our patients on, especially our young patients.
What are some of the symptoms you would say that would trigger, hey, I really need to seek professional help?
Yes, absolutely. So with Crohn's disease, if you have abdominal pain, that's just not going away. If you're having severe abdominal pain after meals, that is persisting for more than a few days, then that's perhaps a sign that you should go start with your primary care doctor first. If you develop bloody diarrhea, if you develop stools that wake you up at night, if you develop fevers or weight loss, or just a general feeling of feeling terrible or off, along with some of these GI symptoms, then these are all symptoms very suspicious for Crohn's disease.
So does it affect a certain gender or a certain age group?
Males and females are affected equally. So it's certainly not gender specific. And typically Crohn's disease, it has two peaks in life. You'll typically see it in people in their second and third decades of life. So basically people are children. So kids in between young teens, adolescents, and in their 20s. And then you'll see a second peak where we're finding now patients in their 60s and 70s are getting diagnosed with Crohn's disease. And those are typically the age groups we see. But in all honesty, with autoimmune diseases, all bets are off. And we've seen a whole gamut of ages, but those are the two most common.
Are there any medications you can prescribe to help control or at least alleviate the symptoms of Crohn's disease?
Absolutely. And this is the key in seeing a gastroenterologist who specializes in Crohn's disease and have a nice discussion with them about the different types of medications that are available to treat Crohn's disease. Now, Crohn's is a chronic medical condition, meaning there's not a cure for this disease, but we have a whole toolbox of different medications that can control this disease, and patients can live a normal, healthy life. So these medicines range from anti-inflammatories called mesalamines to immunotherapies, where they're called biologic agents, where they readjust the immune system so you don't have such a hyperimmune response to the inflammation in your gut. And these are all medicines with the first goal of really controlling symptoms, meaning alleviating the abdominal pain, controlling the diarrhea, having patients gain weight and live a normal, healthy life.
You know, you mentioned some of the medications, resources, and tools. If they don't work, do you have any type of surgical procedure you may perform?
Absolutely. And Crohn's disease, again, when you look at statistics, and we tell our patients, in the initial discussions when they first get diagnosed with Crohn's, sort of what to expect down the road. And unfortunately, the vast majority of patients, up to about 2/3 of patients, will need some type of surgery in their lifetime. And we're not necessarily saying this up front, they'll need surgery, but at some point they may. And that may be including what's called a bowel resection, where we remove part of the intestine. That's done by our colorectal surgery colleagues, where sometimes they need to remove the whole colon. But generally, the goal of surgery is to, again, control the symptoms and maybe remove areas of intestine that have had complications from Crohn's, like a blockage or a fistula or maybe a bowel infection.
Dr. Tasneem Ahmed from Texas Health Digestive Specialists in Plano. Thank you for that information on a disease that, boy, when you have it, it's serious. We're going to bring Dr. Michael Tolle back to talk more about pneumonia, especially with our elderly, next on the Human Side of Healthcare.
Covering the healthcare topics that matter most to North Texas. This is the Human Side of Healthcare with DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
Welcome back. We're going to continue our discussion with Dr. Michael Tolle about pneumonia. Yesterday was a day that we recognize as Pneumonia Day in the United States. So, Dr. Tolle, are the treatment protocols different for COVID and pneumonia?
Yes, they are. So COVID is a specific virus. And so as with any specific pathogen, a pathogen is something that causes an illness. Any specific pathogen may or may not have a specific treatment. We remember when COVID first came on the scene, we didn't have what we would call a specific treatment, something that worked directly against COVID that we knew for sure worked. Now as time has gone on, we do have that for COVID. We have antivirals that specifically work on COVID and are effective in quickly reducing the severity of a COVID infection. Pneumonia, again, can be caused by a virus like COVID or other viruses. It could be caused by bacteria. We most often think of it as a bacterial illness for which we use antibiotics. And so pneumonia, for the clinician, for whoever's trying to decide what to do, the question really is to try to decide what pathogens could be causing the pneumonia, then treat them specifically if possible. Whereas for COVID, once we know it's COVID, we would have a COVID-specific treatment for that. Some of the principles can be the same. Somebody who's severely affected, who stays in the hospital or the ICU, may be treated with a number of things that are the same between COVID and undifferentiated pneumonia. But again, if we know the pathogen, we can treat it specifically most of the time.
Speaking about pneumonia, and now let's talk about droplets. They're coughing, they're sneezing, they're doing it frequently. How contagious is that?
That's a great question. So when we think about viruses or bacteria, again, pathogens that become airborne, there are a couple of different concepts to think about. Most things that are transmitted airborne are transmitted by droplets. Think of like little water droplets that come out when you cough or when you sneeze. We've all done that, and you get a fluid that comes out. Those droplets are, even though they may be tiny, they're actually big compared to microscopic aerosolized particles like what comes out of a cigarette, say smoke out of a cigarette. They're much smaller than those types of particles. The large droplets that we cough or sneeze, those don't stay in the air very long. They don't travel very long, and they quickly drop out. And we think of those being contagious, like when somebody coughs on you or sneezes on you. Things that can become like a smoke particle. Again, think of cigarettes burning and the smoke going out through the air and wafting around. Those can stay in the air and be inhaled in for a long period of time, even for several hours. Now, what's interesting, and of course, COVID can be transmitted either way, by the big droplets that are, say, cough in your face and drop out quickly, or by little aerosolized particles that hang in the air. Interestingly, COVID does not seem to remain infectious very long, even if it's hanging in the air, may not retain its infectivity for a long period of time due to light. Ultraviolet light seems to degrade it, due to perhaps the air circulation, the humidity in the room or outside if you're outside. So even though the particle may be hanging there, it's not necessarily infectious for a very long amount of time.
You know, I've read articles where pneumonia is referred to as an old man's friend. Can you elaborate on that or comment on that?
That's an interesting, that kind of reminds me of the first year of medical school, hearing that term. And that's an interesting term. That actually comes from a gentleman named Sir William Osler, who's often called the father of modern medicine, a Canadian physician. We know him here in the United States as the founder of Johns Hopkins Hospital, and who wrote one of the first real textbooks of medicine at the end of the 19th century. And when he wrote about pneumonia, he talked about how in children and in healthy adults, things usually go well. But he had a statement, something to the effect of that pneumonia is so fatal in older people that it's often thought of as the natural end for older people or older men. And so it became called the old man's friend, really relating to, again, the fact that a young, healthy person typically would recover from pneumonia. And think about when this was in the end of the 19th century and all the things we have now that weren't available then, particularly when it came to antibiotics and medications, whereas for their older patients, it would very often be a cause of death. And that's really relating to the difference between younger and older people and how patients do with pneumonia.
You know, you mentioned generally young people are healthy, and it's the elderly that get pneumonia. But I want to talk about very small children, even infants. How serious is pneumonia in that age group?
Infants are certainly a high-risk group for respiratory infections, no question about it. I think the one that most people are probably familiar with is an infection called RSV, respiratory syncytial virus. This is something that we would typically see in the winter. Although, interestingly enough, we've been seeing it throughout the year, the last couple of years. A lot of the disease transmission patterns seem to have been thrown off by COVID and isolation of people from one another there at the beginning of the COVID pandemic. Infants are most susceptible to RSV, particularly infants who are under 6 months or infants who were born prematurely, for whom the risk may persist longer than that. Infants who have chronic issues, particularly heart and lung issues, so born with a heart birth defect or a lung birth defect. Infants who have some sort of we would say cardiopulmonary compromise are more prone to RSV and particularly to other to viral pneumonias in general. Why are these things worse for infants? Well, infants, like elderly individuals whose natural immunity wanes with age, when you are tiny and young, your immunity is not fully developed, and you're just more susceptible to things. Also, your airways, the size of your airways are smaller, and so it doesn't take much inflammation in a tiny airway to block that airway and to make what would be something, perhaps more routine in an adult, a serious problem in an infant.
You know, we frequently hear the terminology, the individual has walking pneumonia. Can you explain what is walking pneumonia and how is it different from regular pneumonia, if you will?
That's a good question. Yeah, that term also comes from the earlier days of medicine, and you can think about it as someone who has a more serious pneumonia and is having a hard time breathing, certainly not walking around, or someone that has a less serious case, does not have as much of an issue in their lungs, has maybe a little bit of pneumonia, they're able to walk around. We use that term in medicine particularly to refer to a patient who has a cough in particular that lasts for a prolonged period of time, say a couple of weeks or more, and who, when we listen to their lungs, have some sounds in their lungs that sound like pneumonia, as opposed to somebody whose lungs sound totally clear. Maybe we get a chest x-ray and there are patches of pneumonia, or what you might call pneumonitis, but not the complete affecting of one of the lobes of your lung. The classic bacterial pneumonias like pneumococcus would cause one of the lobes. So your lungs are divided into lobes. One of those lobes would be completely affected, called lobar pneumonia. That individual traditionally not walking around. The individual with a patchy, scattered, less severe pneumonia is walking around, walking pneumonia, coughing, prolonged cough. The pathogens are different. The pathogens that cause a lobar pneumonia, again, they're things like pneumococcal bacteria, things that cause these patchy, less severe pneumonias are organisms like mycoplasma and some of the chlamydia species, and that's why your doctor will try to figure out which it is. The antibiotics that are used for one versus another are typically different. And people can have these walking pneumonia bugs for a prolonged period of time, several weeks.
We've been listening to Dr. Michael Tolle, family medicine physician at Texas Health Family Care in Dallas. Don't let that congestion turn into pneumonia. Steve?
Thanks, Thomas. What a great show. For all our listeners, please join us again next week for the human side of healthcare.